Hello, hi, it's Dr. Townsend, of course, Dr. Cat, as you know me by. I wanted to discuss about blockage, okay, and bleeding. Blockage we call ischemia. Bleeding, of course, is related to usually hemorrhage, related to cerebral vascular accidents and strokes. Okay, perfusion, which you have heard, of course, a lot. Perfusion is something we want everywhere in the body. When we are, of course, lacking perfusion, we're unstable, and we want to know what is going on. So let's talk about the brain, okay? What happens if there is a clot, a thrombosis, or emboli that actually ends up in the brain, or we are bleeding? Let's look, of course, over here, related to ischemic, all right, strokes, or hemorrhagic strokes. Ischemic, like we said, would be a clot or an embolism, something that is blocking, all right, which is cause, of course, a lack of oxygen to the brain. Hemorrhagic is a bleed, something that breaks open, all right. It could be caused by a clot, but then, of course, there's a bleeding involved, all right. So you will see a typical carotid artery, and of course one with a clot and breakage that's going on. So think about it. Strokes, or 60%, are related to hypertension, high cholesterol, atherosclerosis, diabetes, obesity. The list can go on and on. So a lot of it can hopefully be managed with lifestyle, which we'll discuss too, or maybe it's hereditary or cultural. Genetics can also play in it. Ischemic strokes are about 87%. There is a different type of stroke. They call it a transient ischemic attack, TIA. You'll hear the initials. It can lead to a stroke. So some people think, a TIA, it only lasts for a short period of time. But it almost, you could think of it as kind of priming you, giving you a hint that maybe you have some issues. Do you have blood pressure? Are you taking care of it? Are you taking care of your diabetes? Are you exercising? Maybe it's the body's way of telling you to make some lifestyle changes or at least get to a doctor. Does have the same symptoms of a stroke, usually lasts less than 1 hour. That's where it distinguishes between a stroke and ischemic attack, a TIA. Risk factors are the same as stroke, as we were just discussing. It is an emergency, so people shouldn't just say, it passed, it's all good. I did have a coworker who did that a lot. She would have her TIAs very young, probably in about her 40s, but she did have blood pressure issues. She was also Native American. She had cultural, and physical signs already. We had to kind of convince her that these things are important and get the help. She actually did listen to us, got on her blood pressure medications, had, of course, MRIs and scans, and never really had any more TIAs because she was actually taken care of. So definitely advocate for people. Try to teach them in a very polite way that they probably need some help. So here we go. Carotid arteries can get very calcified. Arteriosclerosis can get very narrowed. Right down here. Okay. Transient ischemic attack, people end up with a very, very headache. A severe headache is usually a sign. As we discussed already, of course, hemorrhagic strokes, brain bleeds, any kind of stroke is actually related to hypertension. We want to call 911. Bleeding could happen in the subarachnoid or the ventricles, as you can take a look at the pictures. You see A is an epidural bleed, B is a subdural bleed, C is an intracranial or intracerebral hemorrhage. Unfortunately, when they do have a bleed, an intracerebral bleed, half people die within 48 hours. Bleeding in the brain is not something we have much options to help with. It is the worst headache of their life. Mortality rate within 30 days is 40 to 80%. They will get a decreased level of consciousness. They'll be nauseous and vomiting. They will have fixed pupils, could have seizures, stiff neck, paralysis, coma, and death. Hemorrhagic stroke is not a good stroke to have. It's usually more palliative or just symptom management. All right, let's ask some questions. So please think about these. Take a moment to even pause. What is the number one cause of a stroke? What education would a nurse teach to prevent strokes? So let's say you did a community pamphlet or you're out teaching in the diabetic van. We could teach about hypertension and stroke also. What is the difference between an ischemic and a hemorrhagic stroke? And think about what would be the nursing care, which we're probably going to get to. So hopefully you pause for a minute, actually written down these questions. If you had to go back to the back slides, that's okay too. And please trust yourself to recall what you know. All right, let's move forward. A stroke equals a stroke. It is the brain, the location, and time will equal disability. The more time without oxygen, the more deficits there will be. Here's a nice little just picture of signs of stroke for men and women. Any of these signs and symptoms could happen. You could get that numbness and weakness in the face and the arms and the legs. Usually it's one-sided. There could be confusion or trouble speaking or understanding speech. Trouble seeing in one eye or both eyes. People could have trouble walking, very dizzy, lose their balance, and that's severe headache with no known cause. We want 911 or a stroke alert, of course, if it's internal. And the biggest thing we want to do is have a non-contrast computerized tomography, STAT, right away. Now, I want you also to consider who else could get a stroke. Could a newborn get a stroke? If they had a hemorrhage or, of course, they had forceps delivery. Could children? Maybe they have some, background. Pregnancy. Women have the extra blood cells and they can get anemia, but they also could have platelet issues and adherence. So people in pregnancy and even postpartum, unfortunately, are high risk for stroke. So I definitely want you to think of those things while you are in your postpartum and kind of do some research on that. Women can have strokes and they can have hemorrhages. And children. So it's not just older people or people who are out of shape. It could just be even people without hormones, like myself. I'm, of course, postmenopausal. And unfortunately, I could be at higher risk no matter how much I exercise or try to watch my diet. Just being an older woman could definitely be a cause. So, is there stroke? We have act fast. We have that facial droop. So think about it. Put your face down and try to talk. It might be very strange. Your arm weakness. Have the person put their arms out and one's going to drift down or one might not even be able to get up. Speech might be garbled or incoherent. And time is crucial. So we want to act fast, call 911, get the patient in really quickly so we can distinguish what kind of stroke or what is going on with the person. You want to teach in the community about stroke signs and symptoms. What would you teach? How would you teach? Another time I'd like you to kind of stop, reflect, maybe write yourself some notes, maybe even draw a little something, a little pamphlet. Take 5 to 10 minutes just to kind of think about this so it will stick for you. All right, CVA stroke protocols and treatments. The ED to needle time. So we do want the non-contrast CT done, hopefully in less than 25 minutes. Then they might want a CTA, an MRI, MRAs. There could be a lot of other things we may do, okay? Is it a clot from the heart? So would we want to do carotid or cerebral studies? Cardiac. Is it actually a cardiac issue? Do some troponins, creatine kinase, the MBs. Of course, an EKG. Always good to do an EKG. Chest x-rays. Make sure it's not pneumonia. an echocardiograph. Other labs that we may want to add, like PTT, INRs, CBCs, platelets, glucose. Of course, we'll do a glucose. Lipid panels, renal and hepatic panels. The time of last normal. If we want to be able to do TPA, we would want the time to be under 3 hours, the longest 4.5. Other contraindications. What would you think that we couldn't actually do TPA on? Of course, you have to look up TPA to know what that is. But contraindications, one of them would be if somebody had a GI bleed, probably within the last 30 days, or if they're on blood thinners. We'll want to have the oxygen, of course, have a pulse ox at least 95%. And then, of course, is this actually a stroke that we can treat, or is it a stroke we can't treat? And what interdisciplinary care team would we have involved? Oh, crap. Sorry, hit something that I didn't really want to hit. All right, here we go. There's an ischemic left middle cerebral area, as you can see with the arrows. And then the hemorrhagic massive subarachnoid in interventricular areas. It would be a good idea when you are at your clinicals. None of us are, of course, experts on CT reading, but it would be good to maybe pull up the image and read at least the reports to kind of get a feel of what are the differences, and then compare what kind of treatment are we doing as nurses and care providers for each one. National Institute of Health has a scale in stroke care. Of course, when we think about it, what is always important? Airway, breathing, circulation, level of consciousness. We'll want the vital signs, of course. With a stroke, we could have hypertension going on. So we will want to treat the hypertension, but we don't want it to come down too fast. Okay, so we actually have a systolic blood pressure greater of 220 and a diastolic blood pressure of 120. We'll give IV labetalol or nicardipine. These are antihypertensives. You may even want to pause, be able to write these down, or maybe pull out your cards and just kind of review them, and maybe even put these parameters for a stroke. Your IV TPA medication, when you do give that, the systolic blood pressure actually is a little under 185, 110, okay? Maybe 180 over 105 for the first 24 hours for the thrombolytic therapy. You always want 2 IVs. Head of the bed, please keep up 30 degrees. Remove the clothing. Of course, you want everybody in gowns. You want to take a good head to toe. Please have seizure precautions because these people, because of the high blood pressure and with the stroke, they are seizure precautions. So you probably will see some medications for that involved. Of course, we'll keep NPO because we need to do a swallow eval. Now, swallow evals on the floor can sometimes be done by the nurse or they're done by the speech therapist. Depends on who can get there first or who feels most comfortable getting there. So just note what facility, who does it. Of course, you want to know about the level of consciousness, the gag, and swallow. Those are the 3 most important, gag and swallow. Person doesn't have a gag reflex or a swallow reflex, we sure don't want them to aspirate, and we don't want to feed them. So if we can't, what we will be thinking about nutrition, usually within 24 to 72 hours, we want to make sure people have nutrition on board. We want that complete history. What else are you thinking when you see this about stroke? Why are we assessing the cardiac? What are normal lab values and abnormal values? Why a non-contrast CT? Take a little time to kind of investigate these questions before you kind of move on. All right, more stroke care. Of course, we want to prevent intracranial pressure and cerebral edema when someone has a stroke. We also have to consider kidneys. Kidneys just love to shut down. So, sorry, hyponatremia, edema. How is the antidiuretic hormones reacting? What causes hyponatremia and hypo or hyponatremia? How are our fluids and electrolytes going? Oh. Sorry. Maintaining the head alignment. Of course, that elevation of the bed. We want to keep that no fevers going because of temperature. If there is a fever, we could actually have more seizures. All right? So we want to keep that temperature. So we want antipyretics on board. Medications to prevent seizures, and of course, the treatment of pain and prevent constipation, because we give a lot of medications, plus now they might have had a stroke and they're not moving as much. We definitely don't want them straining. That increases intracranial pressure. Ischemic stroke medications. We have our antiplatelets, which make platelets slippery, so they don't clot together. Aspirin, usually an 81 milligram, and then often diprotamol. You will definitely have your Plavix or ticobitines. Of course, there's a warning with the Plavixes. You usually want to hold any Plavixes or aspirins, usually about 10 to 14 days before any procedures. So please teach people that if they are on these medications, that they want to tell their dentist, or if even going for a colonoscopy, to be able to say, hey, these are the medications I'm on. Would you like me to hold them for 10 to 14 days? Atrial fibrillation, if the patient does have heart condition going on, we'll want that warfarin, Xareltos, Plaxida, and the Eliquises. Please know both words. I'm not real good at pronouncing them. I'm still learning, even in so many years. Of course, the statins, simvastatins, lovastatins. Of course, we'll want to keep that cholesterol low, or at least manage it. But don't use these medications for hemorrhagic strokes. Those are different medications. If someone's bleeding, we sure don't want them, of course, having Plavix or other medications that would keep them from clotting. Okay, what is TPA? Who is a candidate? What would be medications for ischemic stroke and the whys? What will be the nursing and interdisciplinary care? Please brainstorm, look at your readings, maybe write a concept map, writing out, okay, this is a stroke, this is a patient that can get TPA, this is a patient that can't get TPA, this is hemorrhagic. What would I do for actually a hemorrhagic stroke? Interventions for strokes. They have balloons and stents they could actually put in to help with improving the blood flow. They can do staples and sutures and clips also. And then they can do the carotid endarterectomy, which is removing, of course, the plaque and the atherosclerosis in the lesions, which is often done. They'll do one side and then later do the other side, not usually do both at the same time. You may want to look up some videos of these just to kind of take a look, or at least some pictures in your book. All right, acute care for a hemorrhagic stroke. As we said, no anticoagulations, no platelet inhibitors. We're going to treat the hypertension either orally or IV, and this parameter is more of the systolic blood pressure under 160. These are precautions, of course, the preventing of the intracranial pressure. This is where they do the surgical clips or the coils to hopefully stop the bleeding. Nimodipine is a treatment cerebral for vasospasms, and it can decrease the cerebral damage of the vasospasms and the bleeding. But before you can give this, please make sure the heart rate is over 60 and the systolic blood pressure is at least greater than 90. If it's not, please hold and definitely call the provider. A lot of supportive care. This is a high mortality rate, so you would definitely, for both types of strokes, depending on, of course, deficits, but it's always good to get the social worker, the case manager involved, educate the family and the patient, and might need skilled, might mean long-term care. Are we talking hospice, palliative care? You'll see those teams on board. All right. Of course, we talked about the safe oral intake. Swallow and gag evaluation by the nurse or speech therapist prior, of course. And unfortunately, strokes can happen to young people and older people. Can they eat? Now, very important on how, if someone had a stroke, and of course, if they have the facial droop or they have deficits, you want them to eat very much sitting up, more high values. See how the woman is sitting in the chair, even the little boy. Stay upright after they eat for at least 30 minutes because we really want them to digest, not get anything aspirated in the lungs. Feed on the non-affected side. Place the food in the line of the vision, so you definitely want to know that they can see it. So some people who have strokes they don't recognize part of their body, or they can't see, of course, out of one eye. You want them to tuck their chin slightly as they're eating, so it goes down, of course, the right pipe. Eat with no distractions. This may sound like why, but we want them to focus. So don't have a TV on. If somebody's with them, probably it's best not to do a lot of talking. And they do ask them to double swallow. Oral hygiene. Why would you think oral hygiene is important? Well, sometimes the food gets pocketed in their mouth. So we want to make sure it's not pocketing and then going down where they could aspirate and cause lung issues. We don't want them getting pneumonia. And then nutrition will determine what kind of foods and consistencies. So when you're on the floor, there's all different kinds of nutrition pamphlets. Take a look, and they do a lot of times need a little more higher caloric intake because they're doing healing, and when you're sick or chronic, it actually takes a lot more calories to get dressed, to stand up, to get to the bathroom. Usually after a stroke, people are definitely more tired, so they are burning more calories and actually need a healthy diet. All right, what are the similarities and differences of ischemic and a hemorrhagic stroke in care? What will the nurse prioritize and anticipate for each type? Please get into groups. This would be a good time for you guys to really think about it. Kind of apply nursing. What would be concerns? What would be priorities? What would be things you would see that maybe families are doing well or not doing well? How can you keep these people safe after a stroke? All right, stroke complications. Unfortunately, the list is extremely long. Someone who's had a stroke and, of course, level of conscious, gag reflex, swallow, they can end up on a ventilator. They could be aspirated or need to be suctioned. We have our SARS and our sepsis. So, of course, we'll do that oral care every 2 hours. What kind of feeding will they need? Will they need an enteral nutritional feeding? Is it short-term, basically just through their mouth or their nose? Or do they need one, of course, elsewhere? Breathe, gag, swallow. Biggest important before trying to feed them. Ongoing nursing assessments. Cardiac, pulmonary, renal, mental health, the family change. Imagine that you were a young couple like this picture, or even an older couple, and your life, one of your partners just had a stroke and they actually have deficits, and maybe they can't go back to work now. Maybe they need to get on Medicaid. Maybe they need to go to long-term care. This is devastating. It changes people's lives. Think about it. Musculoskeletal. If you have one side of your body not working now, do you need a wheelchair? Do you safely can use a walker? How's your skin? If you're actually not paying attention to part of your body, who's going to help you get dressed or make sure that you actually clean that side of your body? Physical therapy, occupational therapy, help people with stroke to still try to pay attention to their bodies and keep things safe. Definitely people end up with GI issues, urinary issues, that quality of life. They may want to change their code status. They were a full code, maybe they want to be a DNR now. There's a lot of grief, there's a lot of loss, and a multi-organ dysfunction, the MOD. So as a nurse, there's a lot of cluster care going on and trying to help people move on to a new life, a different life, or are they deciding that it's time to end their life? All right, here we go. I kind of want to bring everything kind of more together. I know I asked you a lot of questions prior, but here is a good visual. If we have a right CVA, so think about it. If the right side CVA, which is part of your brain, okay, you're paralyzed on the left side, which is called hemiplasia. See the cartoon? All right. Spatial perceptions. All right. Short attention spans. They'll have that visual field deficits. Impaired judgment. So think of it if they're impulsive. Are they trying to get out of bed? Does somebody need to be with them one-on-one? As you can see, if you have left-sided neglect, you'll of course want to dress the left side first, even wash the left side first. So imagine if you're putting on a shirt, do the side that has the deficit first, or the pants, the leg, you'll want to take care of that one. So you have to think of course, the right-sided is the brain stem, but the left of the body is the weakness. Now let's look at the left CVA. Okay, now if the left CVA, it's the left side of the brain, even put your hand there, okay, and then imagine that the right side of your body is of course weak. So this is where a lot of times the speech and the language is an issue. These people actually are a little more slower. They have that fear and anxiety, vision issues, depression, impaired comprehensions. So how, as nurses and healthcare providers and families, how are we teaching them about these deficits and how to cope with them? Usually we'll set goals and start rehab within 24 to 48 hours as soon as a person's stable. Now, of course, if they're still on event 24 to 72 hours, we're not really going to probably progress. But if somebody, of course, had TPA, they qualified, a lot of their symptoms hopefully are resolving because of the TPA, then, of course, we can move forward sooner. All right. Here's some more information of possible effects of your left-sided stroke. Where's the brain injury? And what do we see? So I want you to take a moment and put yourself in a person's shoes that just had a stroke, not hemorrhagic, a CVA. They actually had a clot in their brain, and they have deficits. So, to the left here, we see a person that basically looks like the right side is probably the weakest. And how to roll out of bed? How do they have to use, aids? How to actually get into a wheelchair? Now in the middle, this is what we usually see. But if they have neglect, they don't actually see part of their body. And then all the way over here, we see somebody, of course, getting their left side dressed first, and then their right, and then what they see if the plate is not placed in the right place. So people actually won't feed themselves if they don't actually see the food, or they may not know they need to eat. So sometimes we have to actually help them eat. How would this change your life? Have you seen somebody have a stroke in your life and see how they changed? How did you deal with it? How did they deal with it? You probably heard the word aphasia. Aphasia is an impairment of language, and may affect the ability to speak or to read or to write or to comprehend. People with aphasia caused by a stroke or brain injury have a language disability, not a cognitive or intellectual disability. So imagine, just because they can't speak, their brain is probably thinking what they want to think, and they can get very frustrated. We have to give them time with them. Usually we'll want to talk to them in one sentence at a time and help them get the words. Or maybe they could use pictures. Or maybe if they're still able to write, they could write a word down. How are we going to help them still communicate? All right, stroke risk factors. Number 1, hypertension. Not modifiable risk factors, of course, are our age, our genetics, and hereditary. Blacks and Asians, unfortunately, are more at risk for strokes and even hypertension. Modifiers, of course, we know, is obesity, stop smoking, sleep apnea. Lack of oxygen to your body, your kidneys, anywhere, actually causes us to have many medical health issues. If we are not exercising, of course, that poor nutrition, any lifestyle habits, the hypertension, heart disease, diabetes, if you do have blood clot disorders or sickle cell anemia, okay, or any inflammatory diseases, rheumatoid arthritis. Our goal is to keep our systolic blood pressure, hopefully under 140, and please let us help patients and families understand the importance of taking their medications and anticoagulants for diabetes. And if they are having problems getting their medications or understanding their medications or can't afford their medications, please let's advocate for them to hook up with our social workers and care managers. We do have ways of helping our patients. So please get us involved. I am one of those. Stroke prevention education. We're going to teach about hypertension, keeping that blood pressure under 140, and also teaching people how to actually take a blood pressure correctly. The good way to take a blood pressure correctly is, of course, we want the feet flat, hopefully sitting up in a chair. The arm is at the heart level, okay? The patient is not talking. They're actually quiet. And then that should be hopefully an accurate heart rate. And we do want to partner with our communities and families for stroke education. All right, I got some more questions for you. 1, severe sudden headache, worst headache of one's life, mostly likely a blank stroke. Client has right-sided weakness with difficulty finding the right words. What would the non-contrast CT show? What area of the brain is involved? What are TIAs? What is the blood pressure parameters for clients with a stroke, with and without TPA? Please learn the medications, generic and brand names, and their real applications. You may want to pause the slide and actually write down your answers. All right, keep on learning and be curious. How can a stroke affect newborns, children, pregnancy, and postpartum? Would the care be the same? Would it be different? Write down these questions, and maybe as a team, work out some of them. Mostly everything did come from your Lewis book. Thank you very much.